So when you talk about septic arthritis of the hip, the most important thing to realize is that this is a surgical emergency and requires you to identify it early and treat it early. It often peaks in the first few years of life, and 50% of cases actually occur in very young children under 2 years of age, and then neonate is one of those very tested but also clinically common ages where kids will actually get this. It is an intra-articular infection and it's a surgical emergency, and you have to realize that both the hip and the knee are affected pretty equally in about 35% of cases of each, with the remainder joints sort of making up the rest. Risk factors specific to that neonatal period that we talked about are if you're relatively immunocompromised, so premature patients who were delivered via C-section, and pretty much anyone in the NICU is at risk for the variety of procedures that they may need while they're there. There's various ways in which you can get these infections, and the most common way would be either hematogenous seeding or an extension from an adjacent bone. So just as Dr. Andres talked about, the areas where you can get osteomyelitis where there is an intra-articular metaphysis, these are the same areas that you can get a septic arthritis. So the hip, shoulder, elbow, and ankle are all places commonly tested where that metaphysis can be a problem. And the knee is not one of these locations. So this is the first question. Unfortunately, this is a little bit of a sort of do you know it question, but the question asks which of the following is true regarding matrix metalloproteinases, MMPs, and the answer here is that they mediate the destruction of cartilage in septic arthritis. These are the main factors that actually destroy the cartilage when you have a septic arthritis. And it's sort of a little bit, you see, just sort of need to know it. However, if you do this from a test-taking perspective, all of the others are opposites, but unfortunately you probably or may not recognize all of these other answers. So the pathophysiology of the destruction is that there's these proteolytic enzymes, which are the MMPs, and this basically causes a very big inflammatory response within the joint, and this basically causes damage to the cartilaginous surface. A secondary sort of mechanical aspect is that you have a lot of joint pressure. As you get fluid in your joint in the enclosed space, this can cause osteonecrosis because it basically can stop your blood supply and can lead to that if, in long term if you don't get to it quickly. As far as what organisms cause this, so it varies very much by age, and this table off to the right here is useful. And so you can see that based on the age, you're going to have different organisms. The commonly tested ones in neonates fall into sort of the ones that you get in the hospital, and that is gram-negative organisms or staph. The most common when you are looked at outside of the hospital is group B strep. As you get into the more infant children, again, staph is going to become the most common, and as Dr. Andres pointed out, Haemophilus influenza was commonly a cause of these in the past, but because of immunization, it basically has gone away. As you get more into the adolescent group, you're going to see that you're going to be more, still have staph as the most common, but then Neisseria will also start causing a lot of these joint infections, at least from a test-taking perspective. And then as you get to adults and IV drug abusers, there's other common organisms. The Neisseria is the most common organism in adolescents and is still, as far as test-taking purposes, although clinically I'm not so sure that that's always the case, but it certainly is the way, at least from a test-taking perspective. The reason this is also relevant and the reason that they like to test it is because it's treated in a different way. So whereas septic arthritis for most organisms is treated with IND, the key with Neisseria is you can try to treat this with antibiotics alone. And again, as I pointed out before, group B strep is the most common infection in neonates when it's community acquired. That's very different than if they're in the hospital getting a number of procedures. So another question here, this is an 8-year-old boy, no history of trauma, has a fever of 39, a CRP of 12, which is elevated, an elevated ESR, as well as an elevated white blood cell count. And the question is, which of these is true regarding the most common causative organism? So the key question here is to identify that this child probably has a septic arthritis, and we're going to talk a little bit about the parts of the stem that will help you determine that in a minute. But this kid has septic arthritis, and so you want to know what's the most common in an 8-year-old boy. That's going to be staph. And then you need to sort of know a little bit about the mechanism of these bugs, and staph is catalase and coagulase positive. The others are answers here are a little bit more rare type bugs, so that's why it does not sort of fall under that category. So here's a 2-year-old boy who was initially diagnosed with a septic hip. Initially, no organisms were grown on the standard blood agar. However, an organism was found on the blood culture medium, and they're asking which organism is the most likely cause. I think the key to this question here is understanding that they're saying that this is probably a bug that is not as common, and that's Kingilla kingae. So if you sort of look at this question, you probably can take out the 2 tuberculous sort of mycobacterium type bugs, and then sort of hone in on the one that is the most uncommon, because they're trying to ask it in a different way. So just as these questions try to look at, Staph aureus is the most common organism in kids over the age of 2. It is a gram-positive coccidioid. It is in clusters. And again, this does come up as the most common in nosocomial infections of neonates, although you do need to look for gram-negatives as well. And then there's these more uncommon bugs that do cause septic arthritis that you need to know. The Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella, and I'd say Kingella is probably the most commonly tested. These are a bit fastidious and sort of tough to find when you're looking for them on standard testing, and that's why you need to grow them out on different ways. And so Kingella is isolated on blood culture media, and this is sort of a memorization type option. So the prognosis for septic arthritis is generally pretty good if you get to it early. So the key, again, this is a surgical emergency. The ones that we see turn into disasters are those that are delayed. So the x-ray here is a patient of mine that actually presented late, was sort of passed around for a while, and you can see they also have a associated osteomyelitis. So you can see the cyst here as well, and so they had a bad outcome. Certainly neonates also have a bad outcome, so age under 6 months of age. And the key here is delay means bad outcome, and I think that's the most important thing, specifically when you're looking for treatment. The history that you look for is, do they have any recent local trauma? Again, the vaccination history is important to make sure that they've been immunized against H flu. We basically never see this anymore because basically everyone's been immunized, but certainly if it's a bit weird, then you need to know that. And certainly from a test-taking perspective, it's important. These kids usually present very acutely with a lot of pain that's pretty significant. And if they really are sick, which is not uncommon, they will have systemic symptoms. So they will look toxic, they will look septic. And again, one of the most common things is little kids, when they have a septic joint, really do not want to walk on it, and they often just will refuse to walk on it. If you catch them early, their vitals may be okay, but certainly if they're getting septic, they're going to have hemodynamic instability. They may become tachycardic, they're going to have fever, they may even become hypotensive. And when you look at these, it gets a little bit easier as the kids are older because they will have pain in the hip, or they'll be able to verbalize it. However, when they're little, they often can't. They just say, I'm not going to walk on it. Also, if you're looking at the neonates, at the babies in the NICU, and they have this, they basically will just hold their hip in a weird position. So you can see this picture over to the right here where it's in a flexed, abducted, externally rotated position. So this is a position where it maximizes the space in the joint capsule. So if you have a lot of fluid that's angry in your hip joint, your basically hip is going to want to be in a position of comfort, and that's where it will naturally go, just from a protection standpoint. So here's a 2-year-old boy that has a limp. He had a significant history for a left knee infection treated with IV antibiotics as a neonate. So the key here is neonatal infection. Potentially was sick. It often is not limited to one joint. His laboratory and workup is essentially negative, so labs do not show any current infection. You see this x-ray that looks terrible. It looks like the left hip is essentially missing, and this is a very classic picture of untreated neonatal hip infection. So they can be pretty sick and be treated and cured, so to speak, of their infection, even though they may or may not have had treatment. And the problem is it often causes a lot of destruction in the femoral head. So an absent femoral head in this history certainly goes along those ways. And these other diseases are not common in 2-year-olds. Most of them are in much older individuals. So when you examine these kids, they're often very difficult to examine because they have a significant amount of pain. They basically have pain when you try to move it at all, and that's the sort of hallmark of a septic joint, just as it is for other joints. And in little kids and neonates, we often call it a pseudoparalysis because basically they just won't move it. You do need to look at adjacent joints because certainly adjacent joint involvement is common, particularly in neonates or really young kids that are sick in the ICU. It's a little bit less common in sort of ambulatory, otherwise normal kids. So here's a 7-year-old boy with limp. He has a temperature of 38.4. You can see that his laboratory studies show that his white blood cell count is fairly normal, his CRP is fairly normal, and he has a SED rate that's a little bit elevated. They have an aspiration that shows that basically they have 9,000 white cells in the fluid, which is actually fairly low. So pretty much everything is normal here, with the exception that you are still sitting with an elevated SED rate of 55 and a little bit of a temperature, and he's also not bearing weight. And so those key components here are important, because even though lots of these parts are normal, you need to think about something else going on. And so what they're trying to get you to bite on here is that this maybe is toxic synovitis, but really because of the inability to bear weight as well as the elevated ESR, you need to look a little bit further. And so the answer is to image the pelvis further. And you can see where the answers tend to fall. There's a good proportion that sort of suggests that maybe you should wash this out. But again, some of these things being normal sort of lead you away from that direction. And then the other common one is trying to get you to bite on the toxic synovitis answer here. But again, it's sort of a questionable picture, and that's why you need to think about imaging it further. So what radiographs you get, AP and frog lateral pelvic x-rays are normal. Findings may be normal, especially in early stage of disease, but the sort of hallmark or classic question that you'll see is sort of widening the joint capsula or lateral displacement of the femur. So you can see that this femur is pushed out to the side a little bit, and that's purely because there's basically fluid in the hip joint that has pushed it out. In infants, this may be difficult to see, especially prior to ossification of the femoral head, but it may look like a true subluxation or a true dislocation. Ultrasound is probably the best test. In neonates, you want to always look at the other hip. As we talked about before, it's not uncommon to have septic joints in multiple joints, particularly in the sicker kids that have a lot going on. And this can be used as a guide for your aspiration. And it's most important just to identify an effusion. And what you're looking for is sort of, this is the hip bone or the femur bone here, and you can see these are the muscles. You can see how it's lifted off, and there's some fluid sort of sitting underneath, and that is an abnormal finding. MRI can be useful, but it's not often easy to get, and particularly the very young kids. And if you're pretty sure that it's a septic joint, then generally we tend to treat that and find out a little bit later. However, if they're not that sick and the pictures are a little unclear, then an MRI can help. It can help by both finding a joint effusion, but also looking at adjacent osteomyelitis. So you can see in this MRI here, this is the same case I showed before. He had a septic joint, but he had fairly significant osteomyelitis of his proximal femur. Labs are very useful, and this is probably the most important thing if you take anything away from this talk. There's these 4 labs, and then we'll talk about a 5th lab that has been shown in subsequent papers, but these are the classic Coker criteria for distinguishing your risk of a septic hip. So the things you want to look for in your question stems are a white blood cell greater than 12,000, inability to bear weight, a fever greater than 38.5, and a SED rate greater than 40. And then the 5th one is sort of an elevated CRP. So this is an 8-month-old infant, has fever and malaise. They have an x-ray that we'll see in a second, and they have a temperature greater than 38.5. What has been found to be the best predictor of this child's condition? So this is the picture. He's got the flexed abducted externally rotated hip, just like we talked about before. And this is sort of what I talked about being the next paper. So CRP is actually the best predictor outside of those first 4 criteria. And the test sort of questions will sort of fall in those 2 camps. So we'll talk about that in a minute. So labs are very important to distinguish transient synovitis from septic arthritis. Basically, if none of those 4 factors that I talked about are present, then basically your risk of a septic arthritis is less than 0.2%. The problem, just as it is with osteomyelitis, these labs are not great all of the time. So white blood cells are elevated only about 30 to 60% of the time in patients. ESR can be elevated, but can also show other things, and it also can be normal early in the course of infection. CRP is probably the most important, and the reason is it makes sense because it rises soon. It's up as soon as 6 to 8 hours after injury, and a CRP greater than 2 is an independent risk factor, even when you take away those 4 other criteria. There is a paper which we'll talk about in a few minutes, which shows the sensitivity of the above criteria, shows that fever is greater than CRP, is greater than ESR, greater than refusal to bear weight, and white blood cell count. So this paper has been tested sort of in this way. So this is a 7-year-old girl who brought to the ER her mother for 24 hours of hip pain, again refusing to bear weight, key fever of 38.2, white blood cell of 14, so elevated, SED rate mildly elevated, and a CRP of 5.5, so very elevated. So this is sort of testing that concept. ESR is not that exciting, but has a CRP that's fairly elevated. So what is the next thing to do? Here's the ultrasound. You can see the elevation of the fluid. So you want to get an aspiration. So this patient is fluid, has a risk of infection of about 74% based on the criteria present, but also has an elevated CRP, and that's really what pushes that probability up, and the aspiration is going to give you your answer. This is an 18-month-old, sudden onset of hip pain 3 days ago, won't put weight, so not bearing weight, febrile, has an ultrasound that we can see here, it shows both the affected and the unaffected hip, and you can see the difference between the two because there's a lot of fluid on this side, which is the affected hip, and the aspiration showed 60,000 white blood cells. So the answer for this is it's septic arthritis. So this is the classic presentation, and what this question is trying to get at is what is the synovial fluid analysis that's going to lead you to septic arthritis. Basically, if you have over 50,000 white blood cells, then this is almost most commonly septic arthritis. But even when it's a little bit lower, it's important to know that when you have a white blood cell count between 25 and 75,000, it is the most common diagnosis. This is a 6-week-old who refused to move his left hip. The patient was premature by C-section, and his other one has been healthy. So risk factor, C-section, premature, afebrile, has diffuse swelling about the left proximal thigh, and basically they're uncomfortable when you move it. This is your radiograph, and what you can see here in the radiograph is that the hip looks like it's pushed out to the side a little bit, and the question is what is the next answer, what is the next step in treatment, and it is aspiration. And that's because you have to worry about a septic hip in this premature infant that is refusing to move hip. The key here is if you look at the answers, several people choose Pavlik harness, and this is because it does look like maybe it's a subluxed or dislocated hip in a young child. However, you have to realize that DDH is not painful, so you have to really think infection in this case. So hip aspiration is the best way to confirm a diagnosis of septic arthritis. Your fluid will show a white blood cell count that's elevated, and so you need to make sure you send it off, but you also want to send it off for gram stain culture and sensitivities so that you can direct your antibiotic treatment once you get a bug. And again, a high white blood cell count of greater than 50,000 with greater than 75% PMNs is the most definitive way to diagnose septic arthritis, but again, between 25 and 75, that is still the most common diagnosis, so even with lower cell counts, it's not uncommon. It's generally good in these kids when they're sick to get blood cultures, specifically if they're febrile, because this may be another way that you may be able to get the bug if your aspiration is negative. And if they show any signs of meningitis, then you need to consider aspiration of a lumbar tap, looking for H flu, particularly if they've not been immunized. So this is a little bit of a table. It's a little bit busy here, but it shows the differential for sort of hip pain in kids. And I think there's 3 sort of key papers to realize here. And again, we're going to talk about transient synovitis in a minute. But the first is the distinguishing between transient synovitis and septic arthritis. And these are those variables that I talked about. Those 4 independent multivariate clinical predictors can give you a risk of septic arthritis. Those ones that I listed before, as you can see, if you have all 4 of the factors, your risk of septic arthritis is almost 100%, whereas if you have none of the factors, it's 0.2%. So it's quite useful in determining which way to go after you've sort of taken these kids, particularly whether or not you should aspirate them, move ahead with an ultrasound, or if surgery is the best answer. Michelle Caird then had a subsequent follow-up paper that looked at these factors again, but then added CRP as well, and then sort of looked at the sensitivity between these various factors. And temperature was the most sensitive, followed by CRP, ESR, refusal to bear weight, and serum white blood cell count. And you can, again, see this sort of start sneaking into questions. And this is the 3rd paper where they looked at these factors again and found that CRP and weight bearing were the most important. So again, some combination of those 5 factors are important, with CRP probably being important in the early diagnosis. Non-operative treatment is rarely indicated, but again, the key concept to understand is that if you have a Neisseria infection, this is the one instance that you can treat it with antibiotics alone and try to avoid surgery. And again, this is a testable type question. As far as how often I see it in practice, it's probably a little bit less. So this is a 3-year-old who has a 24-hour history of limping. Again, inability to bear weight is a key part of the stem here. There's no history of trauma. Had a recent upper respiratory infection. They have a clinical photo, which we'll show here, which shows the externally rotated hip, and they also have an ultrasound there that shows some fluid in the joint. Lab values, white blood cell count 15, ESR 120, and CRP. So basically you have almost everything elevated, not wearing weight, lots of criteria are satisfied here, and so what's the best answer? And here it's basically IND. Just take them to the OR and wash it out. I don't think in this situation that they would likely put an aspiration here as an option to choose against it. But I think what they're trying to test here is that you have a very high chance of infection, 99%. It's an emergency. Take them to the operating room and wash it out. So operative treatment, urgent surgical IND followed by IV antibiotics. This is the standard of care. It should be considered a surgical emergency. This is one of the diagnoses that gets you out of bed in the middle of the night to treat it. And basically early treatment gets basically all of those chondrolytic enzymes in there out, and also reduces that intra-articular pressure, which can lead to blood supply issues. Basically, how long do you stay on the antibiotics? Well, it's generally 3 to 4 weeks. Some will follow the CRP or ESR, and clearly if you have a sort of osteomyelitis at the same time, this will lead you to potentially having it a bit longer. You basically want to treat this just like with osteomyelitis with empiric antibiotics to target the bugs that are most commonly to cause the problem, because your aspiration will not always be positive. So basically you want to base this on age as well as medical comorbidities in that graph and table that were shown earlier. And again, immunization status is important here, particularly with regards to test taking to cover H-flu. So this is a 8-year-old infant who is admitted to the hospital for septic arthritis, which is the most likely causative organism. So this is an 8-day-old infant, septic arthritis, but they're out in the community. So the most common causative organism is group B strep. Again, this was listed sort of on one of those earlier slides. If this was a neonate that was still in the hospital, you need to think about staph and then gram-negative bugs. So again, this is the table sort of showing antibiotic coverage as well as most common organisms. So less than 12 months, you need to think about staph, group B strep, and gram-negative, depending on whether you're in the hospital or out. And often a first generation cephalosporin will be able to treat this. As you get from 6 months to 5 years, you need to think about staph, group A strep as well, and if they're not immunized, H-flu. In the 5 to 12-year-old age group, Staph aureus, again, treated with a first generation cephalosporin. And again, if you have MRSA, this complicates things. In 12 to 18-year-olds, you need to think about Neisseria, again, as sort of the one that is more common in the age group, sort of at least from a test-taking perspective. So how do you treat it? It's usually an anterior lateral approach to the hip. Basically, you go in directly, see the joint, open up the joint with an arthrotomy. You remove all the purulent drainage, and basically it's common that we would leave about a 1 centimeter by 1 centimeter area of hip capsule open to minimize the chances of reaccumulation, and then we usually generally leave some sort of drain. You can get them moving pretty early. Actually, if you have a pure septic arthritis of the hip particularly, they do quite well, unlike osteomyelitis, which I think takes a little bit longer to recover. You can get these guys up and move them pretty quick, and they feel a heck of a lot better. So this is a skeletal immature patient, aspiration-proof septic arthritis of the right hip. They've had an IND. Appropriate antibiotics are given. What is the least likely complication of delayed management? So we know that if it's delayed, they're going to have a worse outcome. And so this can lead to a number of things, but it's not going to lead to a chronic posterior hip instability, because generally if this is treated with an IND, it's treated through an anterior approach, so posterior instability is not going to be common. However, if you have delayed treatment, it's not uncommon to have a limb length difference, persistent limping, osteonecrosis, or chronic osteomyelitis. Again, these are all listed as complications of delayed treatment. So complications, femoral head destruction, we talked a little bit before about how if you have a lot of pressure in the joint, this can lead to complete destruction of the femoral head and neck. This is also from those MMPs that are within the joint. If you have deformity, it's because the physis basically gets damaged, and you can have a late angular deformity as well as a leg length difference. Also, you can have, again, hip dislocations, more commonly anterior because of the surgical approach. Growth disturbance and LLD are common. And again, if you have a delayed fashion, that pressure inside the joint certainly can lead to osteonecrosis.
Be sure to subscribe for more content and follow us on Facebook and Twitter at OrthoBullets.